Thank you, everyone, for joining us today for our December Research Corner. Um, Good afternoon. My name is Corinne Pettigrew with the Johns Hopkins Alzheimer's Disease Research Center, and I'm here with my colleague Eileen Rosenthal from the Greater Maryland chapter of the Alzheimer's Association. Today, I'm going to be moderating our event on From Social Isolation to Insight, what research reveals about dementia and social connection. So this topic of social connection is really important and has gained increasing attention over recent years, in part because research is increasingly supporting the idea that strong social connections are vital for well-being, for supporting our mental and physical health, and helping people stay resilient during life's challenges. So to further dive into this topic, we're going to have a presentation by Dr. Mary Louise Pomeroy. Before I introduce Dr. Pomeroy, just a quick note about logistics. Please keep your microphones muted during her presentation, but feel free to put any questions you have in the chat box, and we'll hopefully be able to get to them after. Once Dr. Pomeroy is done presenting, then we will take some audience Q&A. So with those logistics behind me, it's my pleasure to introduce today's speaker, Dr. Pomeroy, who is a health services researcher at the Johns Hopkins School of Nursing and principal faculty in the Center for Equity in Aging. Her research focuses on improving aging in place for older adults with limited social connections, particularly those living with dementia. She examines how social isolation influences avoidable healthcare use and how community-based services can strengthen social connection. Dr. Pomeroy earned her Master's of Public Health from Johns Hopkins and her PhD in Health Services Research from George Mason University. So with that, I will stop sharing my screen.
Are you all able to see my screen?
We sure are.
Okay, great. Well, thank you so much, Corinne, for having me and for bringing up this really important topic as part of the Research Corner. My name is Mary Louise. Corinne, you gave a lovely introduction. I don't think I need to do much more. I'm a health services researcher by trade at Johns Hopkins School of Nursing, and I am a bit of a talker, so I'm going to do my best to try to keep this within 15 minutes. I did want to briefly acknowledge my funding and my amazing collaborators at Johns Hopkins and elsewhere. And I have no financial disclosures to report. But I did want to disclose that this topic is very near and dear to my heart. I have two pictures here of my grandfather, who I called Poppy, who was really integral in my upbringing. My father passed away when I was 6 from brain cancer. And so my Poppy moved in to help support me and my upbringing alongside my mom, and was just a huge influence in my life growing up. Fast forward about 25 years to when I returned to school to complete my master's in public health. He was living in Florida and had a stroke, and relocated from Florida to live with me and my mom, who I was with again during my master's. And, I think he began to develop some signs of what we think were probably vascular dementia. He was an extremely social person prior to his stroke, part of a big family, one of 11 kids. And I noticed that when he moved to DC to live with us, that he was really losing a lot of his social connections from the relocation. He was increasingly withdrawing from the community, spent more and more time sort of sitting in his chair watching his Westerns. And it was just really striking to me how someone who had been such a social butterfly and who still had pretty robust caregiving support could still kind of experience this level of loneliness and isolation that he was. So I miss him very dearly. He's passed since then, but he serves as inspiration for a lot of what I do now. So this is a brief roadmap of what I'll be trying to cover today in our 15 minutes. I wanted to do some level setting to begin with, and just provide some basic definitions and contextualize why these issues are important in the larger policy landscape as well as in the context of dementia. I'll talk a little bit about the bidirectional relationship between social isolation and dementia and some of the mechanisms that may affect those pathways. Then I'm going to talk a bit bit about some of the key research that has surfaced around social isolation as a risk factor for future dementia and cognitive decline. And then on the flip side, I'll speak a bit about my work looking at dementia as a risk factor for social isolation. I'll touch a bit on social isolation in the context of caregivers who are providing care for persons living with dementia. And finally, hopefully, we'll have some time to go over some recommendations and things that you can do. So I really wanted to start with one key takeaway, if you remember anything from this presentation, and that is the distinction between social isolation and loneliness. Social isolation is a very objective, quantifiable experience. It's defined as the lack of or limited social contact and relationships with others. This can be both at a personal level, such as at home, living alone, how often you have contact with others, as well as at the community level, so things like volunteering, participating in religious service activities, groups, clubs, organizations, things of that nature. And I also want to acknowledge that social isolation isn't always necessarily perceived as an unpleasant experience. In fact, some people, given personality differences, etc., might actually prefer more isolated environments, for instance, introverts, and they might actually see this experience as preferred. In contrast, loneliness is sort of this subjective counterpart of social isolation that's referred to as the experience of feeling isolated, feeling alone, whether or not you are. It's described as a mismatch between one's actual versus their desired level of relationships and contact. And compared to isolation, it is inherently distressing and an unpleasant experience with a low sense of control or choice. I want to distinguish these two experiences, not only because they're different, because they're actually very weakly associated. There are many individuals who are isolated but not lonely at all, and many individuals who are lonely but not isolated. So, for instance, on one hand, you might think of someone living in a rural environment, but who's quite happy. They have a dog and they're content being more isolated. And in contrast, you might think of someone who's in a very unhappy marriage. They may not be physically isolated from others, but they might be extremely emotionally lonely. And then additionally, these two experiences are associated with distinct healthcare outcomes. Loneliness is often more closely associated with poor mental health outcomes, things like depression, anxiety, suicide as well. In comparison, social isolation is associated with things like cardiovascular disease, and dementia is a really big one. And so for this presentation, I'm going to be focusing on that association between social isolation and dementia. This is just a quote that has really sat well with me and I think does a nice job illustrating the differences. That isolation is like being stranded on the moon, whereas loneliness is like being stranded in the ocean and dying of thirst. So, to provide a little bit more context, these were two very seminal reports that have come out really since the COVID-19 pandemic. And I would point you toward them if you're interested in this topic more. The first on the left was released by what was previously the Institute of Medicine. It's now the National Academies of Sciences, Engineering, and Medicine. And this was one of the first key reports that really synthesized the research evidence that helped distinguish isolation from loneliness and really started to fuel scientific interest in the topic. It came out just before COVID. So once COVID happened, this really served as a great bedrock of information for people who are interested in the topic and catalyzed a lot of research. Of course, then COVID happened and further sort of elevated public interest in this topic. I think everyone to some degree was experiencing social isolation, and that really brought this problem to the forefront. And then on the right, more recently in 2023, the previous Surgeon General Vivek Murthy under the Biden administration sort of made this his bully pulpit topic. He really took a prominent position on social isolation and loneliness and gave it a national platform by making it his signature issue, further really disseminating public awareness, but he also outlined this is a key public health priority and even outlined a sort of a national next step agenda in order to tackle the issue. So I do want to acknowledge that isolation and particularly loneliness are really big problems across the age spectrum. For instance, some of the highest levels of loneliness we see are actually among our youth, our young adults and adolescents. But in the context of aging, isolation in particular poses some really grave concerns. So the first is the rising prevalence of dementia. We think that over the next 25 years, the prevalence of dementia is going to double among our older adults. And plus our aging population, we're expecting about 90 million older adults by 2050. Isolation in the context of dementia poses some serious concerns. And it's not just dementia, it's that dementia often is accompanied by medical complexity and comorbidity, which also require a lot of social support to manage. Yet at the same time, we're seeing these demographic shifts in the US where older adults are increasingly not married, experiencing late life divorce. We're having fewer children. With the rise in technology, we're seeing more distance caregiving. So it's this double whammy of sort of this increasing need among older adults for support, yet demographic shifts that are suggesting there is less of it, less of that social support. And this is important. We see that social isolation is associated with about a 30% increase in the risk of mortality. That's akin to smoking about 15 cigarettes per day in terms of its impact on premature death. So I wanted to talk about sort of this dynamic relationship between isolation and loneliness, and dementia. So here's sort of this vicious cycle diagram. And we think that social isolation is a risk factor for dementia. That Surgeon General's report I mentioned a couple slides ago found that looking at all the evidence, social isolation was associated with about a 50% increase in the risk of incident dementia. And that's huge. There are a lot of various mechanisms we think may be responsible for this relationship that I think are still more theoretical, and there's more research needed to really unpack what's going on under the surface. But I've put some examples here at the top. Things like, for instance, reduced cognitive stimulation when you're having fewer interactions with people, as well as the mental health implications of isolation, things like depression, anxiety, stress, that can in turn increase inflammatory processes that are linked to dementia, such as elevated IL-6 levels and CRP levels. Additionally, isolation is associated with negative health behaviors quite often, things like lower physical activity, smoking, drinking alcohol, and then just instrumental support, lack of social support, lack of access to transportation, to health resources, things of that nature that are required to help maintain health and prevent or delay dementia onset. But we also think this cycle is bidirectional. And I think there's a lot less research looking at the association between dementia leading to more social isolation. We think that from our research, which we'll talk a little bit about in a minute, about 35% of people living with dementia are socially isolated. And these are very likely underestimates because people with dementia who are isolated are also the least likely to participate in research. So we may not be as readily able to pick up on this population and its epidemiology. And as I mentioned, future work is needed to really elucidate these pathways. But we think that the psychological and behavioral symptoms of dementia may lead to isolation, so things like aggression, social withdrawal. Of course, stigma associated with dementia may reduce people's willingness to go out into public. And then some of the functional impairment that make it physically less possible to go out into the community, as well as becoming homebound. So there's a lot more research out there than I can cover in my time, but I wanted to highlight a few really seminal studies that you can point to for research on this topic. So the first is a Lancet Commission report, which it basically looked at all these different modifiable risk factors for dementia and used this method called population attributable fractions to say that about 40% of the risk for dementia is potentially modifiable. And among these different modifiable risk factors like depression, smoking, inactivity. Social isolation is responsible for about 4% of dementia risk. And then likewise, there was a key study that came out of the United States from colleagues of mine at Johns Hopkins that looked at dementia incidence across 9 years by social isolation status. And they found that among over 5,000 older adults who are part of a nationally representative sample, the risk of developing dementia was 27% higher for people who are socially isolated compared to those who are not. And this was a stable finding across demographic characteristics, including race and ethnicity. Now, on that flip side, looking at dementia as a risk factor for isolation, that's really where most of my research lies. And this is an example of actually two studies looking at healthcare outcomes among isolated individuals. We generally find that about 20% of older Medicare beneficiaries are socially isolated. Among those with dementia, it's much higher. It's about 35%. And you can see here on the left that social isolation scores, higher scores, were associated with more nursing home entry. You can see sort of that green line here. So that's a major outcome. And if you're interested in looking at hospitalization, on the right side, we found that respondents who are living with dementia who are socially isolated had a 9% increase in their probability of being hospitalized within any given year compared to counterparts living with dementia who are not isolated. I also wanted to touch on this idea of social isolation among dementia caregivers, which I think can appear at the surface as a counterintuitive idea. You know, by nature of being a caregiver, you're often with the person living with dementia. But we're increasingly seeing that sort of these caregiver, care recipient dyads are living in isolation together. So, I have some figures here, but basically we're finding that about 16% of all caregivers for persons living with dementia are isolated, and that this is even higher among male caregivers. About over 21% of male caregivers to persons with dementia are isolated. So I think that we need to be keeping an eye on these individuals in our community. So I wanted to wrap up with some recommendations for what you can do to address this issue. First of all, I always recommend starting proximal. When you're thinking about this topic, reflect on yourself and also the others or people around you. These are some questions you can ask yourself. Have they stopped their usual activities? Are you seeing them as frequently outside their home as you used to? Do they have a chronic health condition that could be exacerbating or causing isolation, particularly things like hearing loss that make social connection more difficult? And then for those who are close to you or for yourselves, really thinking ahead, planning for future interactions with the healthcare system, you can be proactive by making sure that if you are isolated or the person has fewer social connections, they have advanced directives in place, surrogate decision makers identified, and caregivers documented in their medical records. And on the right, I've just provided this sort of self-assessment that has been developed by AARP, which I think can be helpful. Sometimes people realize they're isolated. In a lot of instances, we don't necessarily recognize this. So I'd encourage you to take the assessment and see what your own profile looks like. And then I provided my slides to Corinne in case you want access to these resources. But these are all different recommendations that you can do to increase your own social connection and actual concrete resources in the larger Maryland community that you can do to increase connectivity. And I also wanted to just acknowledge that this isn't just isolation, loneliness aren't just problems, but that social connection is actually highly beneficial. We see better associations with health outcomes, reduced burden of disease, improved cognitive function, longer survival times, civic engagement. So it's not just a detriment, but also there's a lot of really great outcomes you can achieve by increasing your own social connection. So I can't believe it. I think that was 16 minutes, so I'll stop there. There is so much more to cover, and I'm happy to answer any questions on the topic.
Excellent. Thank you so much for that fantastic presentation. We should have
Sure.
given you 45 minutes just so you could dive
I could
into
take a whole
everything
hour, but
more.
I won't do that to you.
Excellent. Um, if you have, let's take a couple minutes for audience Q&A to see if we have any here. Does anyone have a question they want to jump in with for Dr. Pomeroy? If not, I can start with one. Can you talk a little bit about how social isolation interacts with other risk factors such as depression and cardiovascular disease or hearing loss being another popular one?
Mm-hmm. So, yeah, I mean, certainly there are, like, from a statistical standpoint, significant interactions, I think, with all of those issues. Um, Social isolation is a funny thing because for people who are otherwise quite healthy, it's not necessarily detrimental. And in fact, in a lot of our analyses, we see more positive outcomes for people who are isolated, which I think is an artifact that we're actually picking up on these people are just healthier in general. But it's really in the context of chronic illness, severe sensory loss, where this becomes a problem. So you can imagine trying to manage cardiovascular health. Social isolation is increasing things like inflammation that are directly increasing cardiovascular risk. It's also indirectly increasing risk through things like reduced physical activity, some of those other negative health behaviors, and transportation to, for instance, preventive appointments, not having someone to help you manage a complex medication regimen to take care of your cardiovascular health. So there are both sort of direct and indirect effects on your cardiovascular health outcomes. And I think you can find parallels for other things as well. You mentioned hearing impairment, not being able to, you know, connect with people because it's difficult to talk on the phone with them, for instance, can further impact your hearing, but also kind of create this cascade of other health issues, things like dementia. So it is really multifaceted, and I think it becomes a true problem in the context of managing chronic illness alone.
Yeah, thank you. We did have a question in the chat. What advice do you have for families whose loved one is reluctant to engage socially? And I think we can think about this both from individuals without cognitive impairment, possibly as well as for
Mhm.
individuals living with maybe early cognitive impairment and trying to promote social engagement.
Yeah. I think that's tough because of a lot of the personality, differences inherent to isolation and loneliness and how those differences drive these experiences. My recommendation is, well, I have a few. The first is to usually bring in sort of an outside objective perspective. That could be something as simple as bringing up this issue at the doctor's office, um, and trying to have sort of an outside perspective. I think that can be more impactful on behavior change than if it comes from the caregiver or the friends. Um, I also think trying very hard not to stigmatize these issues, and part of that is sometimes avoiding the language. So avoiding direct questioning, like how often do you feel lonely or do you feel isolated? Although sometimes people are happy to talk about those things. But sort of backdooring your way into these questions, like, so what is it like since you received your dementia diagnosis? Do you find that you're going out less? Are you doing the things you enjoy? You can sort of get to these questions by sort of building that rapport first. Um, the self-assessments are another option, but I think a big part of it is also just patient and person education about why these issues are important. It's not just about making friends. They have real health impacts, and I think driving that point home, the early mortality akin to 15 cigarettes a day, those types of statistics can help reframe the issue, reduce the stigma, and create a recognition of why they matter.
Yeah, absolutely. Absolutely. Thank you.
Sure.
Um, oh, this is an interesting question. Do you think conversing with Alexa or AI to mimic social conversations will help someone that is embarrassed about their dementia?
This is such an interesting question. It's a very hot topic in our field right now. Um, and I'm still learning a lot about AI myself. I first came to the first thing I will say is that in person is always better. Always, every time. There's nothing that can replace in-person real human contact. With that said, I think in the past I've come with a lot of preconceived bias and stigma against the use of AI, particularly in young adults. We are seeing a lot of use of chat bots, for instance, and companion AI bots in our young people, which is worrisome to me. But I am trying to come around to a more holistic view that this is just an inevitable part of our future and that there may be roles where these bots can play, have a meaningful impact. And I think that that role is in the context of aging and dementia. Um, Older adults who are in nursing homes, for instance, who have less contact or ability to get out into their community, people who are homebound and physically are unable to engage outside the house. I think that there may be a role for AI, chatbots, whatever the technology may be to help boost social connection, provide some sort of meaningful conversation, and continue to increase cognitive stimulation. But I think it's a slippery slope. And again, to be very clear, in person, nothing can replace that. So I think there's a role for these new technologies, but one that we have to balance carefully.
Absolutely. And I think you see that in even the professional setting as well. The in-person meetings tend to be so much more productive
Yeah,
than online. Um,
absolutely.
we have two more slides that we want to present as co-sponsors of the event, the Alzheimer's Disease Research Center and the Alzheimer's Association. If you wouldn't mind, while we're doing those, kind of trying to touch on a couple points in the
Sure.
chat, that would
Happy
be
to do
great.
that.
Thank you
Thanks so
again for
much.
such a
And you're
fantastic
welcome to reach out to
presentation.
me with any questions offline too. I'm always happy to engage. Thanks for being
Excellent. And
here.
we did record the event, so we will send out the recording afterwards, as well as a copy of your slides, the PDF that you provided. Thank you for sharing those. All right, so let me share my screen one more time. Just want to briefly mention, so as mentioned earlier, I'm with the Alzheimer's Disease Research Center at Johns Hopkins, and we have a lot of different types of ongoing research studies, including observational studies that involve coming in for tests of your memory and thinking abilities and maybe being followed over time, brain imaging studies that provide information about how your brain changes as you age or among individuals with memory loss, as well as intervention studies and clinical trials testing new treatments for memory loss. We're always looking for new participants, so if you're interested in learning more, you can go to alzresearch.org or email us at jhadrc@jhmi.edu. And I'm happy to answer any questions about that if relevant. And then I'll turn the floor briefly over to my colleague Eileen Rosenthal with the Alzheimer's Association.
Okay, hi everybody, and thank you, Dr. Pomeroy, for a wonderful presentation. And we want you to know just a couple things before you leave. I am with the Greater Maryland chapter of the Alzheimer's Association, and just want to make sure everybody leaves with knowing that there is this 24/7 helpline that you can call any time of the day. Anybody you know who's a caregiver should have this on their refrigerator, because you can talk to a live clinician who can answer almost any question you can put forward. We also have over 50 support groups in Maryland and memory cafes. Some are virtual, some are in person, some are specialty groups. And we also have ongoing education programs around the state, virtual and in person. And so we just want to make sure that you all know that there are resources there. Lots of great online resources, including All's Connected. And then we have a brand new app called My All's Journey, which is really available from the Google Play app and the Apple Store. But it puts a lot of useful information at the fingertips of the care partner or even the person who's recently diagnosed, who just wants to know what that landscape looks like and how to navigate it, and information that may be readily available. So just the most important thing again is that helpline number, because if you didn't get anything else, that's the number that can connect you with all of the resources and services that are available. So thank you all for being here today.